Dr. Studnicki, I'd love to chat with you about your acuity study. What was the most interesting or surprising finding from the study?
Well, I don't think we found anything that surprised us, really. One of the most interesting aspects of the results was the fact that we saw a great increase in the incidence of miscodes between the two time periods that we looked at. As you know, we looked at the 2004 to 2015, and then the 2016 to 2023. And what we found was pretty much a doubling, if you will, of the incidence. This is interesting because it demonstrates the fact that this is just not a problem of coding errors. If we had a systematic coding error for a particular item, we'd be unlikely to see such an increase from one time period to the next. It'd more or less be stable, and they're always trying to eliminate coding errors. It might even go down. But in this case, the incidence of the miscodes is going up. And what that suggests to me is that the abortion industry is being successful in teaching the industry providers and in teaching patients to mislead. That is working. And not only is it happening following chemical abortions, but that phenomenon is also, we found in this data, is bleeding into the surgical abortions as well. So the visits following surgical abortions are also beginning to be miscoded, which we didn't see previously. So it's very concerning in that sense, in that it means that the system is less of a surveillance system and less of a reporting system. It's being compromised by the instructions from the abortion industry to women who receive abortions.
Now, how does miscoding affect patient safety and care?
That's probably the key question as far as the women are concerned. And of course, we already know from previous research that we've done on miscodes that if you have a miscode, you're much more likely to experience a hospitalization following the emergency room visit. And that's probably because what happens is that the physician will make decisions that delay treatment that could have been provided if the woman had indicated that she'd had the chemical abortion. But because she doesn't indicate that, and because the physician is working under the assumption that this is a natural fetal loss, a miscarriage, then he or she is likely to delay certain services. And what we found from a previous study that phenomenon doubles the likelihood that this woman will come back to the hospital in a short period of time for an inpatient hospital admission for removal of the retained products of conception. So we already know that happens. This most recent study also demonstrated that these miscodes are more acute. In other words, for all of the reasons that a woman comes to the emergency room, if you look at the reason and the treatment that she receives, we find that miscodes have a higher level acuity than those that are properly coded. And that goes across a whole range of different kinds of problems that they may experience in the emergency room. So there isn't any doubt about the fact that the miscode puts the woman in increased danger of hospitalization and results in a much more serious emergency room visit. The visits are much more likely to be considered either severe or critical if she's miscoded.
Can I ask you to explain what acuity means?
Well, the acuity we use in this study is the exact same acuity system that was developed for the federal government in order to pay for emergency room services. And it's based on two dimensions. One is the seriousness of the presenting complaint. How bad a shape is the woman when she arrives? And then the second dimension is the complexity of the treatment required in order to treat her condition. And based on those two dimensions and a whole series of questions that are asked related to those two dimensions, the emergency room visit is put into one of 5 categories of severity from the least to the greatest. And we get our data by looking at the 2 highest levels of severity categories 4 and 5, which are those that are severe and critical. And that's what we use as our measure. So it's something that no one is contesting the validity of this methodology. It's been around for decades. It's used to pay for services. Everybody uses it. All the third-party payers use it. All of the hospitals use it. So there should be no concern about the validity and the reliability of the method of assessing the acuity of the emergency room visit.
So if anybody really wanted to, they could go and replicate your study and come up with the same findings.
Absolutely, no doubt about it. Very, very easy to do as long as they have any data set that's drawn that is derived from claims payment, because and they all use the same system for determining acuity. If you used our data set, you would get exactly the same results that we got.
And that's supposed to be good science, right? If you can replicate
That's
it.
good science because it's replicable. Yes.
Can I ask you, why is it important to have good, accurate data on abortion drug complications?
We need good data for fundamentally 2 reasons, but they're correlated reasons. The first, of course, is we need good data to be able to determine something about the complications of various kinds of drugs, devices, and procedures. So we need to know what happens to people when they're subjected to any procedure, whether it's a therapeutic regimen or something like an induced abortion. And when we do good science, that feeds good medical practice. In other words, an informed physician, a physician who knows the science, who knows the evidence-based practice, is a better physician. So both medical practice and the actual development of the science, and those are the same thing, really, 2 sides of the same coin, if you will, but they both demand, in fact, valid data. And that's why it's so very, very important that we have surveillance systems and data collection efforts in the country where we can make these assessments so that we can serve the needs of women and their providers.
The United States, unlike other countries, doesn't do a very good job of collecting data. What would you recommend if you were in charge?
Well, the United States has a very, very inadequate system of reporting pregnancy outcomes of all kinds, including abortion. The states report voluntarily. Some states don't report at all. California still doesn't report to the CDC. I think California, Maryland, and New Hampshire still do not even report even incidence data to the CDC. And of course, California has 25, maybe at least 20% of all of the abortions in the United States right now. And so that means we have bad data. I mean, if we have incomplete data, and then the data that we have is not uniformly reported, and many of the variables that would be of interest to us are not available, and that data set is not associated or linkable to other data sets. There are countries in the world who put all of this together. The Scandinavian countries in particular, for example, have what are called pregnancy outcome registries. So each and every pregnancy outcome, whether it's a birth or an abortion or a natural fetal loss, like a miscarriage, those are reported and recorded at the time they happen. The data is then linked to other registry systems in those countries. For example, death certificates. So if you're interested in deaths that result from an abortion, in that country, you can identify them all because we can link the death certificate to the abortion. We can't do this in the United States. Okay, that's one of the reasons why typically deaths related to abortion are undercounted dramatically in the United States. Those data are also those outcome data, pregnancy outcome data, are also linkable to health services utilization databases in the Scandinavian countries. So that if a woman has an emergency room visit, or if she has a hospitalization, or if she takes certain kinds of drugs. All of that is linkable to the pregnancy outcome, that pregnancy outcome and or other pregnancy outcomes. So with that kind of a database, you can begin to capture, first of all of the information, and you being sure that it is relatively comprehensive, that you're getting most, if not all, of the women, and that you can link those events to other events that you can assess in terms of whether or not they represent some danger, some complication, some harm, something that would be informative for the patient's physician to be able to maximize not only the oversight, but the level and type of care that the patient would receive should anything go awry.
Dr. Studnicki, what key takeaway or message do you want people to get from your acuity study?
I think this is the big message here is a message of trust. And I would ask people who look at this study to question why it would be that your provider of any service would purposefully instruct you to mislead, to conceal, to lie. Why would anyone do that? What would be the reason that anyone would do that? And would you continue to trust a provider who asks you to conceal? These are the same providers of abortion services, who tell you that when you go to the emergency room for visit, if you need to following an abortion, that those are for observation purposes only. These aren't serious visits. And yet we just showed how the overwhelming percentage of women who go to the emergency room following a chemical abortion now have a visit that's considered severe or critical, and in some cases, actually life-threatening. So for people who are listening to this and looking to this, especially women who are considering having an abortion, and especially a medication abortion, a chemical abortion, ask yourself about the motivation of those people who are providing you, presumably, with a helpful service. And is that the kind of provider you trust? Can you continue to trust your provider if they want you to mislead?